Well, welcome to this edition of the Cataract Specialist. Today, I'm going to be interviewing Gerard, otherwise known as Ged Ainsworth, founder and lead surgeon of Lakeland Vision based in Penrith in Cumbria. Ged is a legendary surgeon, and full disclosure, I have to confess that I was so impressed by his surgery, I actually asked him to carry out my mother's cataract surgery. So, Ged, welcome. Can you tell me a little bit about your career to date?
Yeah, thank you, Simon. Thank you for very much for asking me to be on this. Well, so I've been a consultant based in North Cumbria since 2006. So as an NHS surgeon, started in 2006, offering anterior segment surgery. So I do cataracts, I do cornea, and I also offer a glaucoma service for North Cumbria as well. Um, in 2008, I set up my own clinic, Lakeland Vision, really just for my private practice to help differentiate that with my NHS. I worked that private clinic through the NHS at the time. But after about 5 years, I just found that it was quite a difficult combination of working my private practice through the NHS. So then I sort of moved Lakeland Vision out, and as of about three years ago, uh, managed to get my own premises and operating Lakeland Vision, offering clinics, operating facilities. Have two colleagues who've joined me, so we do ocular plastics as well and offer VR opinions as well. And that's gone from strength to strength. Also, full disclosure as well, I'm a director for New Medica in Newcastle as well. So I wear about three different hats. My time as an NHS consultant, I have previously been clinical director. I think I did it on two separate occasions, so for 6 years in total. So we're trying to keep the department running there and trying to move things forward. So yeah, since 2006 really. So coming up to 20 years, which seems an awfully long time.
We're all getting very old, aren't we?
Yeah, yeah.
And Jed, if you weren't an ophthalmologist, what job do you think you'd be suspiciously good at?
Ah, so something which sounds completely unrelated to ophthalmology and medicine. I didn't actually go into medicine thinking, so I come from a bit of a medical family. My father was a GP, I had two brothers who were GPs. I went into medicine thinking I was going to be either an orthopedic surgeon or do general practice, but it was very early on in the second year medical school I decided I wanted to do eyes. But actually, I've always been a fanatical skier as well. So if I wasn't doing medicine, then it would be a life in the Alps for certain. And actually, I'm now working towards my level 2 ski instructor license. So I'm a Basic 1 and a UK snow sports instructor level 1. So it would definitely be something outdoors in the mountains. And that's probably why I've ended up working and living around the Lake District.
That's fantastic. Sounds extremely glamorous, Jed.
I wish it were if it didn't rain quite so much.
Now, look, turning to cataract, if that's okay with you,
Yeah, yeah.
what's the funniest thing that a patient has said to you during cataract surgery?
Oh, goodness me. Um, I I remember operating on a patient and a colleague from a different specialty just came in and I remember them saying, Jed, do you mind if I just ask you something? And before I managed to say anything, the patient piped in and said, "Well, I mind." I said, "Keep your mind on the job."
I take
I'm
it
trying.
wasn't my mother underneath
No, 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 no,
the
no, no, no,
drapes.
it wasn't. I'm just trying to think. So yeah, I've had lots of other things. I'm not sure how repeatable I can say.
Indeed, this is a PG rated video. You're absolutely
Yeah,
right.
yeah. There are certain things which have slipped out, which I've realised that could be taken the wrong way
Indeed,
during
indeed.
operating. But yeah, most recently that's what's pops to mind.
Now, are there any parts of cataract surgery that still make you hold your breath, even after doing tens of thousands of operations?
Yeah, interesting you should say that actually. I sort of calculated back of a packet. So I think I've done around about 30,000 cataracts now, 30,000 lenses. Um, and people do ask you, does it become so routine? And yet I still sit down and every cataract to sit down is unique. Every pupil dilates by a different amount. Every cataract is different density. What are you going to find at the time of surgery? Um, I think I would say it is that X factor where, the first thing makes that any subsequent steps, if you have any problems, any subsequent steps become more difficult. So as long as these sections are fine, I still, I'm often that holy grail of the absolutely perfect Rexis. I don't use a laser, it's all manual. And I think if my Rexis is good, then the rest of it just does seem to flow from there, really.
Yes.
I'm a big proponent now of using silicon tipped IAs, so I don't like using any metal tips for doing the IAs. And I think that's improved the safety, certainly the IA stage, and going in and polishing the capsule. I'm a lot more comfortable with doing that.
Yeah.
I moved to a vertical chopping for taking out the cataracts, and actually it is much quicker, but I feel as though it's a lot safer as well because you're dealing really within the anterior half of the lens. There's very little furtling around in the background.
Yes.
um and then most recently, I mean, there are two things I'd say I've learned in relatively recent stages, sort of in the last 5 to 10 years for cataract surgery. um One most recently is taking out the side instrument, your second instrument, when taking out the last segment to try and just maintain that stability, so that the keeps the PC back when you take out the last segment. Um, I used to
Absolutely.
be I used to be very suspicious of that, and because I was always told, use your second instrument, put it on the side so it protects the PC. But actually, since taking it out, and I think it was Larry Benjamin who said, take it out, it's a lot safer. And since doing that, I have, I'm a convert. I'm a definite convert to doing that.
Very much.
Um, so the other thing was something I picked up from a BSRS conference many years ago, which was doing this Wong incision, which is basically an anterior stromal puncture. So instead of hydrating the section, the two edges at the time of surgery, at the beginning of the operation, I do a 1/3 stromal puncture in front of my section, do my normal section, and at the end of surgery, I just hydrate that anterior stromal, and it closes it. You're hydrating the top, if you like, of the section, and it just pushes it down.
Yeah. And
And
just to be clear for our viewers, this is the Wong incision after David Wong rather than the wrong incision, which you shouldn't be doing.
yeah, exactly, correct,
Yeah.
correct. And so yeah, so you will find it on YouTube as anterior stromal puncture.
Yeah.
But for me that just revolutionized closure at the end of the operation. Just found
Absolutely.
everything really rock solid.
Good for you. Now, Jed,
Yeah.
what single innovation do you think will genuinely transform UK cataract surgery over the next decade?
Ooh. Well, the last couple of things so if you look on my wish list, things I'd like to see which be more applicable, which we could get into surgery. Keeping my eye very much on this capsule laser. As I was saying, the holy grail of getting that perfect Rexis. Well, this capsule laser, which just it's your laser which is just doing the capsule for you. That gives a really rock solid, round, perfect capsule. I think if we could get that such that it's easily available and you can get that on most microscopes, that would be really, really good. And the one thing that I've really hankered after is easily available intraoperative aberrometry. So you're checking. I know things are going to vary when you put your lens in. Your anterior chamber depth is going to vary, but for things like managing astigmatism, if you're doing LRIs or toric alignments, if we could get something which is a very easy intraoperative aberrometer put onto the microscope, I think that would improve outcomes immeasurably.
I'm sure you're right. Now,
Yeah.
do you foresee a future where cataract surgery in your professional lifetime becomes fully robotic?
Ah, yes. Good question that I have thought about. I don't think it will be in my lifetime. I think the degree of precision required is obviously it's a very high degree of precision. The thing is, there's a bear behind every rock when doing cataract surgery. Unforeseen things happen, and how is the AI and the robotics going to deal with that? I'm sure that there is a lot that they can offer, and I really hope I still have a job, a job as a surgeon. Um, but yeah, is it going to happen in my lifetime? I think there's still a lot of hurdles to encounter
Yeah.
before it's fully robotic. I'm sure it will happen eventually. Whether it's going to be in the next 30 years, I don't know. Possibly. Maybe I'm just being a bit pessimistic, but
Yes, you may live longer than that. You never know.
yeah, absolutely. Absolutely. Yeah, yeah.
So, Jed, what are your views on bilateral same-day cataract surgery under local anaesthetic?
Okay, so I would be a hypocrite to say that I didn't agree with it because 80% of all my operating is immediately sequential bilateral cataract surgery. So I firmly believe socioeconomically for the benefits of the patients that bilateral surgery has a major benefit to play. It's not right for everybody. Um, so patients who have, you know, problematic eyes with problematic pathology, if they've got significant sort of diabetic maculopathy, people who are at risk of developing cystoid macular edema, that those are the people I would be a bit reticent to offer. But there are so many benefits to offering immediately sequential cataract surgery. Um, for me, the main one is balance between the two eyes. So I hear this argument quite a lot about refining your surgery, about operating on one eye, looking at what the results are, and then refining it to the other eye. Now, that's all well and good, but you have to think who is that treating? I think, to be honest, that's treating our egos as to
Yes.
how well we can get to zero. Um, what patients perceive, and I'm sure you've noticed this, is is imbalance, asymmetry between two eyes. If the vision is the same in both eyes, patients love it. If you've got a patient who sees 6-4 in one eye and 6-5 in the other, they'll say, "What's gone wrong with this eye, the 6-5 eye?"
Yes.
And you go, nothing's gone wrong with it. It's just, that's just how it is. And if you do them separately, then they think, well, you've not quite got it right there, have you?
Yeah.
Whereas I find with bilateral, when you're basing it, and the degree of biometry nowadays is so good. With the OCT derived biometries, the accuracy is so good that I think that level of accuracy is there.
Yes. I agree with you.
Um, and the old argument of, well, what about infection? Well, since the ERS study, and we're using intracameral cefuroxime, those risks of infection are the benefits of having bilateral, having immediately balanced eyes far outweighs those risks. I mean, there's a risk of the patient coming back for the second eye. They could be in a road traffic accident. So it's I think it's so much better. And I've never had a patient regret having both eyes operated on. I have had patients regret having delayed sequential cataract surgery. Um, I have had them say, "Oh, I wish I'd had both eyes done at the same time."
Yes. Yes, absolutely. And what about so-called drop-less cataract surgery? What are your views on that?
So I've got a mixed feeling about it, to be honest. I can definitely see the benefits, and I do have patients asking for it. And in certain cohorts of patients, elderly patients who have difficulty putting drops in, then obviously, it's the obvious answer. Um, my concern is I do see patients with steroid response. Now, I know recent papers have shown that the degree of steroid response and cystoid macular edema, well, there's been no episodes of steroid response. Well, I would just say to that, well, just wait. I'm sure it will come. And if you've given an orbital floor injection or a subtenos injection, then you then have to manage that pressure rather than just stop the drops, which is a much simpler way of managing that pressure. But there are benefits. There's definite benefits to doing it. I can see that it. I think everyone's in an individual. You have to treat each patient individually, and therefore weigh up the merits. And if the patients can manage with the drops, and you talk to them about it, I'm a big firm favour of giving preservative-free drops where possible. Um, um, I don't see there being too much of an issue with that, really.
No. And a question really for our lay viewers. Which aspect of eye surgery do you think the public understands the least?
Oh, probably. I don't know. So they should understand that, cataract surgery, you're there, you're removing something you can improve vision in that respect. I think one would be glaucoma. because it's very difficult to get the point over that if you're operating on glaucoma, it's there to really try and manage a risk factor of lowering pressure. You're not improving the situation.
Mm.
You're just trying to stop further decline. And that sometimes it can be quite difficult, to get over. And if quite commonly people say, "So I no longer have glaucoma," you say, "Well, no, you do have glaucoma. I'm afraid you always have glaucoma. It's just that it's been treated with an operation."
Yes.
Um, so I think glaucoma, because it's a difficult one. I remember um, once being advised in the training, that glaucoma is almost a philosophy, in that you have to get over the idea of, what is going on. It's the idea of a balance of probabilities. Um, so yeah, I mean, I find it tricky just talking about it to patients in clinic. So
Yes,
it's not
absolutely.
clear cut.
No,
So I think that's a difficult one to describe.
they're certainly hard
Um,
concepts to convey, aren't they?
yeah, they are indeed. Yeah, yeah, yeah.
So, Jed, what advice would you give to someone who's about to undergo cataract surgery? In a nutshell.
Um, I would say be clear that it's something that you want. Don't be guided by other people, by your friends, or being told that you've got a cataract. Just because you've got a cataract doesn't mean that you have to have cataract surgery. And so I always work, and on the premise of three questions, which I say to all my patients, look, the three questions are you having a problem with your vision? Is it attributable to cataract, which is what I'm there for? I'm there to tell you. Is it due to cataract? And then the third one is, do you want something doing about it? It's amazing how there is a proportion of patients whose vision is affected by the cataract, but they don't need to drive. They're not driving. They're quite happy with their level of vision. So then I have to say to them, well, look, there is a risk. And how would you feel if, that risk is very small, but if you were to have a problem and I left you worse off, how would you feel about that? If you're not having a problem at the moment. So be clear in your mind that you want to have something done, where you feel as though you're gonna have a benefit.
And if it ain't broke, don't fix it.
Don't fix it. Absolutely, absolutely. Yeah.
So, Jed, two more questions.
Okay.
If you had to have cataract surgery yourself tomorrow, and it's
Yes.
2025 at the moment, which lens would you choose to have inserted and why?
Oh, and I'm not I'm not I have no financial interest with any lenses, unfortunately. Um, what would I have done? So my workload recently has changed quite a bit because of cataract waiting lists. I'm doing a lot more refractive lens exchange, of which I'm putting in multifocals and extended depth of focus lenses. I must admit, most recently, the patients who I think have just had an outstanding outcome, are those where I've put an extended depth of focus lens in, but aimed for a blended vision.
Yes.
I think they have ended up with a superb quality of vision, with reduced risk of, dysphotopsias, so the halos and the glare, and their near vision has been comparable to those patients with multifocal lenses.
Yes.
So for me, I would go for an extended depth of focus, of which the one I use at the moment is the Johnson Johnson Pure C, with a view to a blended vision. Um, I do sort of test that before surgery, just make sure that they can accept a bit of a sort of a +1 blur in their non-dominant eye. But yeah, that tends to be what I'm suggesting. I go through all these options with patients, and the patients ultimately have to make their own mind up as to what they want.
Yes.
Um, but increasingly, I see that is actually the most that's what most people are choosing because of, if you say to someone, I can give you a good range of vision, but there's a risk of halos and glare with driving at night, or I can put this lens in, less halos and glare. And you know what? We can just fudge things slightly to increase your reading. Most people go, I'll have the less halos and glare, thanks. I'll go with that.
Yeah.
Yeah.
It makes sense, doesn't it, really?
Yeah, yeah. I don't know if that's your experience. I don't know what you would do, but that's what I would do anyway.
Very sensible, I think. So we know what lens you'd like put into your own eye. Jed, who would you choose to be your own surgeon if you had cataract surgery tomorrow?
Oh, Simon, of course that has to be you.
Oh, how very sweet. What about an affordable option, Jed? Something more local.
Oh no, there are. Yeah, I mean, there are lots of very good surgeons around. I don't feel as though I can name names really.
Oh,
I don't want to make enemies. I don't want people to feel sort of particularly uh um uh, as though put one above another. I do have a very good friend who I'd love to go, who would I would love him to operate on my eyes, but he's based in Perth in
oh,
Australia.
well,
So it'll
that's
be a
all
long
right.
way to go, but
That's all right.
yeah. So a big shout out to Rob Paul there. Definitely would let him do my eyes. Also, a good friend of mine, and you'll know him as well, Tom Butler, very safe surgeon in Great Yarmouth. I would absolutely allow Tom my eyes anytime.
Absolutely. Thinking back to our heydays in Nottingham, I do remember Tom and your dear selves, and you're both on a very short list of people I'd let operate on me. So there you go.
Bless you.
Jed, thank you so much. It's been a great pleasure chatting to you, and I hope you've enjoyed yourself.
Yeah, thank you, Simon. Thank you very much for the invite. It's been an honor. Thank you.